A very good evening to everyone. This is Dr. Shubham, and today I'm going to discuss yet another important topic, that is benign prostatic hyperplasia, BPH, a very important topic from the surgery side. So if we talk about the BPH, basically this is the hyperplasia, right? Hyperplasia means there is an increase in number of cells, right? We usually study in the pathology that difference between the hypertrophy and the hyperplasia. Hypertrophy is the increase in size of any kind of tissue, and whereas hyperplasia is the increase in number of cells or increase in number of tissue, right? So here we're talking about benign prostatic hyperplasia, means the prostate cells are going to multiply in themselves, and they will be called as hyperplasia. Okay, that is the reason they will be called as hyperplasia, and this is not the malignant condition as such, this is the benign condition, right? So this is basically the benign hyperplasia, right? This is basically the benign hyperplasia of the stromal cells, right? Benign hyperplasia of stromal cells and the epithelial cells, right? Stromal cells and the epithelial cells of prostate. Okay, epithelial cells of prostate, that leads to LUTS. Now what is this LUTS? LUTS is nothing but lower urinary tract symptoms. Lower urinary tract symptoms, right? So don't worry, I will be talking about them, that what are these lower urinary tract symptoms, LUTS. So this is basically the benign hyperplasia of the stromal and the epithelial cells of the prostate that leads to the LUTS, which is the lower urinary tract symptoms. Now what is this lower urinary tract symptoms, right? So if we talk about the LUTS as such, LUTS, right? LUTS, then very simple, right? These are basically your, for example, post void dribbling, right? After the urine there will be dribbling. Okay, dribbling of the urine, fine. Now next thing is increased urinary frequency and urgency. Increased urinary frequency and urgency, right? Then urination during the night time, right? Urination during the night time, that is the nocturia. Okay, or weak urinary stream. Weak urinary stream, right? So these are some of the symptoms which are covered under the LUTS or the lower urinary tract symptoms. So these kind of symptoms are very common among the BPH patients, right? So let me just go through this image as well, so that I can really make you understand what I'm talking about. So here on the left side you are seeing the normal picture of the patients, right? I will not call them as patient, like normal persons. So here in the males, what you can see is that, yes, here is the bladder. Okay, so this is the bladder, which you can see, normal bladder, and then the bladder, okay, then it is continuing into the urethra, right? So this part over here, this is the urethra, right? This part over here is the urethra. Then you can see that this is the prostate. Okay, yes, this part is the prostate, right? You can see this part is the prostate, right? So this is the normal prostate, and you can see the urethra is wide open. Urethra is wide open, so that there is enough ample amount of space so that urine can facilitate down through the urethra, right? Whereas if you will compare this picture with this particular picture, okay, with this particular picture, this is the BPH patient, and this is the BPH patient. Okay, so this picture, if you will compare, what you can see is, you can compare the size of the prostate over here. If you will compare the size of prostate, here this is the hyperplasia. So here what I can see is, this is the hyperplasia, this is the hyperplasia of what? Prostate. This is the hyperplasia of the prostate. Okay, and due to this hyperplasia of the prostate, what it is doing is that it is compressing the urethra. It is compressing the urethra, isn't it? So it is compressing the urethra mainly. So here you can see there is wide open urethra, but here I can see that there is compression of the urethra, right? Due to this compression of the urethra, what will happen? Here the urine was having the enough amount of space to facilitate down through the urethra, but here the urine will not have that space. That's why urine will not be able to pass into the urethra, whereas urine will actually start to accumulate in the bladder only, and if the urine will be accumulating in the bladder for a very long period of time, then obviously it increases the risk of UTI in the patient. It increases the risk of urinary tract infections in the patient. Sometimes what happens is it can actually cause retrograde flow of the urine back into the ureters. Here are the ureters, and that can go into the kidney as well, and there it can cause hydronephrosis. As well, due to the backflow, due to the retrograde flow of the urine, right? So that could be count as a complication of the BPH, right? So I hope I was able to deliver that message, that what I was talking about, that there was a benign hyperplasia of the stromal and the epithelial cells of the prostate that leads to the that results in the LUTS, that is the lower urinary tract symptoms. What are the lower urinary tract symptoms? I told you that nocturia, weak urinary stream, urinary frequency and urgency, post-void rippling. These could be the reasons for that, right? So one very interesting fact, that most of the patients, while you will be dealing with in the urology department, most of the patients which are coming into the emergency or in the hospital, they are actually, if you will see the age of these kind of patient, this BPH occurs in fifth decade of life. What do I mean by that, fifth decade of life? I mean, like after the 50 years of age, or after 45 years of age. So that would be the age group. The young patient as such will not present as the BPH. However, they might present with the BPH, but generally they are not presenting with the BPH, right? So more than 45 years of age approximately, that will be the age group in which you will be seeing the BPH kind of symptoms, right? So that is also one more idea from where you can get, yes, this patient might have the BPH, right? Okay. If you talk about the pathogenesis is not that clear as far as this BPH is concerned. Some says that with time there could be the chronic inflammation of the prostate, and that might lead to this particular problem. Okay, so it is not that clear as far as this BPH pathogenesis is concerned. Okay, but there are some risk factors. Which the patients might have, and they might be having the BPH in future, or you can say that these could be the associations which you can link with the BPH, right? So what are those associations I can talk about? For example, obesity, obese people. So this is the risk factor. Then you can say that the persons who are having diabetic or hypertension people, like hypertensive people, they might be having the diabetic people, diabetes, okay, DM2, type 2 diabetes, or metabolic syndromes, the patients who are having metabolic syndromes, right? So these are some of the risk factors, or you can say it can be associated with these kind of syndromes, right? So that's kind of a risk factor. Now, how these patients will be presenting to you, right? What could be the signs and symptoms? So what could be the signs and symptoms over here? So let me tell you over here, we are not very much relying on the investigations as such. As far as BPH is concerned, we are more relying on our clinical diagnosis. Okay, we are relying more on the clinical features of the patient, how the patient, it is the clinical diagnosis. Actually, we don't rely much on the investigations part. Okay, so presentation will be very simple over here. For example, the patient will be coming up, two kinds of conditions can be there. One could be that they might be saying that they are having the storage problem. Okay, urinary storage problem. So this could be the issue in some patients, right? In some patient this could be the issue. In some patient there could be the issue of urinary voiding, right? Urinary voiding means they are not able to excrete out their urine. So these are two kinds of classes where the patient will be presenting with, and they will be talking about two kinds of symptoms over here. Let me just define you more clearly that what I am talking about really, right? For example, some patients will be saying that I am having a problem of nocturia. In the night time they are actually going again and again to the washroom. Okay, they'll be saying that I am having increased urinary frequency, right? They might say that they are having urinary incontinence. They are not able to hold down on their urine, right? they might be saying that there is urgency of the urine, right? They are not able to go to the washroom even, meanwhile they are just doing it in their pants, right? These could be the symptoms of the urinary storage. They are not able to store the urine as such. Okay, immediately they are feeling that urge to urinate, and meanwhile they are not able to just go to the washroom also. In the midwhile only they are actually passing their urine. On the other hand, there could be the voiding symptoms, right? Voiding symptoms, like they might say, these kind of people might say, okay, this is the line basically. So these kind of patients, they will be saying that they're having problem with the voiding as such, that they might be having the weak urinary stream, right? They might be having the weak urinary stream, right? They are not able to urinate as such. They might be having the hesitancy in the urination, right? They might be having the hesitancy in the urination or hesitancy while urination, right? They are just standing in the washroom and they are not able to void the urine. Then there might be post void dribbling, right? There might be post void dribbling. Again, these all are these lower urinary tract symptoms, isn't it? So these are some of the symptoms which the patient might tell you if we are talking about the BPH. So both of these symptoms will be including under the BPH. So some patients will be talking about the urinary storage problems, some patient will be talking about the urinary voiding problem. These are the two wide ranges of the presentation part or the symptoms part as far as BPH is concerned. Okay, I hope I am very clear till now. Now just moving further, talking about once the patient will be coming to you, then you will be trying to do the physical examination, I'm sure. So while physical examination, what you will be trying to do actually? So in the physical examination part, I will try to palpate the basically prostate. So I will be doing what? I will be doing the digital rectal examination. I will be doing what? I will be doing the digital rectal examination. I'm just writing DRE. In the DRE, what will be my what will be my idea? So over here during the digital rectal examination, I will try to feel the prostate, and if during that process I am finding that the prostate is non-tender, the prostate is smooth, okay, the prostate is elastic, or the prostate is form enlarged, right? Form enlarged, I will be thinking that yes, this is the BPH, right? This is the BPH. Okay, whereas in the prostate cancer, if you are examining the prostate during the digital rectal examination, if you are finding tender nodular kind of prostate, then it will be going toward the prostate cancer. But if you are finding that the prostate during the digital rectal examination, you are finding that prostate is non-tender, smooth, elastic, okay, and firm enlarged prostate, then it is probably the BPH only. It is probably the benign prostatic hyperplasia. This is also one of the method which confirms your diagnosis in your mind that yes, you are thinking in the right direction actually. Okay, got my point. Now we are going towards the investigations part. However, I told you that this is basically purely a clinical diagnosis, and on the basis of presentation only you make your diagnosis, and your physical examination just confirms that. But still, what kind of investigations you can actually take help of, so that you will be having no doubt in your mind. So what are the investigations which we can talk about over here? So if you talk about the investigations as such, you can go for the urinalysis, right? You can go for the urinalysis, and in the urinalysis, what I will be doing, basically I will be checking for if there is any kind of UTI over there. Okay, because I told you that patient will be having, if the patient will be having BPH, the patient urine will be accumulating inside the bladder, and that can lead to the UTI basically. So for that I need to go for the urinalysis a part over here to just to check upon the patient that whether this patient might be having the UTI or not, right? So to detect the presence of UTI, basically I will be checking for that, right? UTI plus or minus. Okay, for that I am doing the urinalysis. Then next what I can do is I can check for the PSA, prostate specific antigen. Okay, however it is not that specific, but usually prostate will be very high in the prostatic cancer patients, right? So that could be the case over there. Okay, what is PSA? Prostatic specific antigen, right? Prostatic specific antigen, right? Okay, usually it is very much elevated in the older age people who are having the what prostatic cancer, okay, or prostate cancer. Okay, fine. So what will be the diagnostic criteria if somebody will be asking you? Very simple. It is based upon the clinical diagnosis. The patient might be having the storage kind of symptoms or the voiding kind of symptoms. Okay, whatever it is, you can just feel that, and during the physical examination you will be fine. If you are finding the non-tender, smooth, elastic, firm kind of enlarged prostate, then yes, you are thinking about the right direction. That is, you are thinking about the BPH, benign prostatic hyperplasia. That would be my strategy, that will be my diagnostic criteria for the BPH, right? I'm very clear till now. What could be the differential diagnosis? Yes, so what could be the differential diagnosis over here? So there are some differential diagnoses. For an example, let me tell you over here, prostate cancer. In the prostate cancer patient, I told you already that during the digital rectal examination, you'll be finding that there could be the nodular kind of tender or nodular kind of prostate while doing the examination of the rectum, digital examination of the rectum. There might be the prostatitis, but in the prostatitis you might be seeing that TLC count and all. Like investigation, the investigation you will be seeing that it will be enlarged, the patient will be having fever and all of those infection kind of symptoms the patient will be having. The patient might have UTI, very much possible, urinary tract infection, obviously the patient might have. So it can be easily confused with the UTI. Then there can be the bladder cancer, right? There can be the confusion between this bladder cancer and the BPH and all, right? So these are some of the differential diagnosis as far as the differentials are concerned over here. Now coming to the important part over here, that is the treatment. So what would be the treatment you will be going for, right? Once you diagnose the disease, everything is done, investigation part is done, everything, you have ruled out the differentials also. So now coming to the treatment part. So in the treatment part, there are two methods basically. One could be the medical management, right? One could be the medical management, and another one could be the surgical management. Very simple. One could be the medical management, another could be the surgical management. In the medical management, we are talking about broadly, we are talking about the alpha 1 blockers. We are talking about the alpha 1 blockers. What alpha 1 blockers I am talking about? For example, I am talking about the terazosin, right? I am talking about the terazosin. I am talking about the tamsulosin. I'm talking about the tamsulosin, right? So these are the drugs which I'm talking about in the alpha 1 blockers category, right? Some specifications about this alpha 1 blockers over here. For example, they can be given initially in the treatment. They can be given initially in the treatment part of the BPH, right? So initial therapy in the BPH, we start with the alpha 1 blockers. Why this is the initial therapy in BPH patient? Because they start to show their effect earlier, right? So they shows the immediate relief, okay? They shows the immediate relief, right? They results in the immediate relief, okay? The results in the immediate relief. That's why they are considered to be first line as far as the BPH is concerned, but they should be given with caution in the patients who are already on the phosphodiesterase 5 inhibitor such as sildenafil, right? Why is it so? Because they can cause severe hypotension. So that is one of the warning which you need to consider in your patient while giving the alpha 1 blockers, right? So contraindicated along with PDE5 inhibitors, right? For example, sildenafil, right? Now or which you call it as Viagra. Okay, another class which we are having over here, that is the which you can give over here, that is the 5 alpha reductase inhibitors. 5 alpha reductase inhibitors. Okay, 5 alpha reductase inhibitors. And what drug I am talking about? In the 5 alpha reductase inhibitors, for example, I am talking about the drugs such as finasteride. Okay, so in this category, they can be used as an alternative treatment in the patient with lower urinary tract symptoms, right? Because they will not show the immediate effect, but they need some time to show the effects basically. Okay, so who are not very much comfortable with the alpha 1 blockers, we can just try the 5 alpha reductase inhibitors. So it's kind of a alternate therapy, right? It's kind of a alternate therapy basically for those patients who are not tolerable to or who are not tolerative to basically alpha 1 blockers, right? So it takes time. So as I said, it takes time for around 6 to 12 months. It takes time for around 6 to 12 months to show their effects, okay, to show their effects basically. Okay, and in some patients who are coming up with the erectile dysfunction, they can be given PDE5 inhibitors, but again I told you disclaimer over here that PDE5 inhibitors should not be given with the alpha 1 blockers, as they can cause severe hypotension. Okay, this thing is clear. Now coming to the surgical management, also I told you about the medical management. Coming to the surgical management over here, so it would be TURP, right? Surgical management, I'm sure you must have heard about it. That is the TURP. Okay, surgical management, TURP. What is TURP? TURP is very simple: transurethral resection of prostate. Transurethral resection of prostate means you will go through the urethra and you will just burn that, you know, hyperplasia part of the hyperplasia of the stromal and the epithelial cells of the prostate, right? So that is the TURP basically. Okay, who are unresponsive to the medical management, you can go with the surgical management, that is the TURP, right? But in patients, in this kind of patient, there could be some complications related to that. For example, the person might be having the complications. What could be the complication related to this particular problem, this particular treatment basically? Some person might be having the, you know, complaints of retrograde ejaculation. That is very common. Retrograde ejaculation. Okay, retrograde ejaculation, that while while ejaculating, okay, the sperms as such are not ejaculating through the penis, but they are just going back into the bladder, and they are coming afterwards in the urine, right? Sperms are coming afterwards in the urine. That is the retrograde ejaculation presentation. So that could be the complication after the TURP, transurethral resection of prostate. So transurethral resection of prostate, who will be the who will be the patients in which we need the TURP? So the patients who are not responsive to the medical management, for example, alpha 1 blockers and the 5 alpha reductase inhibitors. And in the practical scenarios, we are just using the combination over here. So we are just giving both kind of drugs. If you are talking medical management, we are giving the combo, right? We are giving these drugs in the combination so that we can get the better results, right? So even if that is unresponsive, then we can go for the surgical management, that is the TURP, right? And for those patients, for example, who are having the recurrent UTI again and again, or who are having the stones in the bladder, or some gross hematuria is there due to the BPH, these kind of complications might be managed with the BPH, managed with the TURP, I mean, right? Okay, fine. So as such, overall, what could be the complications of the BPH? I told you complication of the TURP, surgical management of the BPH, but what could be the complications in the overall picture? So complications will be like for the BPH, right? Okay, so obviously if the BPH is happening again and again, or the recurrent BPH, or the BPH is there for a very long period of time, then obviously it can cause what kind of problems? So it can cause UTI, as I told you already. It can cause nephrolithiasis, right? Nephrolithiasis due to the retrograde flow of the urine back into the ureter and into the kidney. Then bladder stones might be there. Bladder stones, that could be the possibility. Then in some patient there might be the hydronephrosis. I told you in the initial part of this video as well, hydronephrosis due to the retrograde flow of the urine back into the ureters and then finally into the kidneys. Okay, and then in some patient they might present with a CKD also. In the recurrent recurrent BPH patient, some patient might land up with the CKD as well, right? Okay, so this was the thing about the BPH. Slowly the patients are just going towards this particular stage. So it is very slowly progressing disease, BPH. Usually the patients are presenting after the 50 years of age, right? So usually it occurs in the 5th decade of the life basically. Okay, so let's just try to apply some knowledge into the MCQs as well. So how they can ask you the questions upon this topic. So a 73-year-old man presents to a 73-year-old man presents to his primary care physician complaining of increased urinary frequency. Okay, let me just highlight this thing. Okay, so he is 73-year-old, look at the age as well, and complaining of what? Increased urinary frequency, right? Okay, it means they are having the storage symptoms, right? Storage problem, nocturia, and incomplete emptying after void. He is otherwise healthy with no active medical problems. Examination was done and you found that digital rectal examination, I mean a large symmetric form smooth prostate is palpated, but otherwise the exam is normal. Which of the following is a potential complication they are asking you? Potential complication they are asking you of this patient present condition. First of all, just diagnose this present condition. Diagnosis is very simple. They are talking about nothing but benign prostatic hyperplasia, BPH. Now just remember the complications of the BPH. I told you about the complications, right? What were the complications? Yes, UTI was a complication, nephrolithiasis, CKD, hydronephrosis, right? These were the complications over here. Bladder stones, these were the complications as far as BPH is considered. So among these options, the suitable answer would be the, yes, that could be the hydronephrosis. Yeah, that could be the hydronephrosis. Why hydronephrosis? Because I told you that if the urine will be collecting in the bladder for a very long period of time, it can go back into the ureter. Retrograde flow of the urine might happen into the ureter, and through the ureter it might go into the kidneys, and there it can cause the storage of the urine back into the kidneys. That will lead to the hydronephrosis. So that's why potential complication of this particular disease, this particular condition, which is BPH, would be the hydronephrosis among the given options. Next question, they are saying that a 70-year-old man presenting to the physician with difficulty initiating a stream and post-void dribbling. Now they are talking about which kind of voiding kind of symptoms, right? I told you two kinds of symptoms in the beginning in the presentation part. One is the storage symptoms and another one is the voiding symptoms. So here they are talking about in the voiding symptoms. In the last question they were talking about the storage symptoms. So here they said that he also reports having increased urinary urgency also. So both kind of symptoms they are talking about, and a weak urinary stream. Medical history actually is significant for hypertension also and not on medication. So I told you hypertension is kind of a risk factor. It can be associated with the hypertension. On digital rectal examination was done and his prostate is actually enlarged, non-tender, firm and smooth. Again they are talking about the BPH kind of symptom, right? So urinalysis is unremarkable and PSA, prostate specific antigen, is elevated, right? So he started on tamsulosin over here, tamsulosin, which was alpha 1 blocker, right? Alpha 1 blocker to improve the lower urinary tract symptom, LUTs. What is the diagnosis, guys? I'm sure you are very much clear about that. Yes, that would be the BPH, benign prostate hyperplasia. I'm very sure that you are not having any kind of doubt in your mind regarding this, right? So this was the presentation about the BPH. I hope you enjoyed the session, and if you did, please like the video, share it with your friends, and please consider subscribing my channel. Thank you so much for joining this one. I will see you in the next one. Bye bye, take care.